New Mexico has struggled for years with high rates of drug and alcohol abuse, as well as poverty and trauma. And how can we treat these issues together to ensure better outcomes for our communities? To start a conversation about this issue, I'm joined today by Dr. Anjali Taneja. She is Executive Director at Casa de Salud in the South Valley. Jennifer Weiss-Burke is Executive Director of Serenity Mesa in Albuquerque. Dr. Snehal Bhatt is Medical Director with the Addiction and Substance Abuse Programs at the University of New Mexico Health Sciences Center. And Lauren Reichelt is Director of Human Services in Rio Arriba County. Thank you all for joining us today. Jennifer, you entered the world of addiction when your son, Cameron, died of an overdose, and you worked to open a treatment center. What kinds of mental health issues do these young people face as they struggle with addiction?
We've seen with my son, he was 18 when he passed away, and I think a lot of his issues were undiagnosed because I didn't really realize that he had them, but I think he struggled a lot with anxiety. Mm-hmm. He had a lot of, and I think he started smoking marijuana at a young age, and I think that kind of calmed his anxiety, unbeknownst to me. And then when he found opiates, that kind of really helped him. I think he was doing a lot of self-medicating. At Serenity Mesa, we see all kinds of mental health issues, anything from PTSD to extreme trauma.
And these are young people.
Yeah, these are young men is what we see, age 14 to 21. So we see a lot of anxiety, a lot of these young men have experienced a lot of bad things in their life, and early childhood trauma and even PTSD, sometimes maybe not before they started using drugs, but once they started using drugs, then they see and do things that have caused them to have PTSD as well.
When they go through detox before coming to Serenity Mesa, but that doesn't mean they're cured. Right. So what do they do at Serenity Mesa to address the underlying emotional issues they're going through?
So the detox is really just the initial stage to get the drug out of the system and to get them stabilized so that they can start a treatment program. So at Serenity Mesa, we take them post-detox, so they have to be off drugs for at least 4 or 5 days. And then we start with intensive outpatient programming, therapy, both individual and group. We do family work, we do a lot of life skills, and we just kind of meet the individual where they're at. So we do individual assessments to kind of see where are they, what kind, a lot of it depends on what kind of drugs they were using, how long they were using, what their family background is like, what their criminal history is like, and we individualize their treatment as much as possible to just kind of not only addresses substance abuse, but then what other issues do they have going on that we need to address as well.
How long do they stay with you usually?
We ask for a 90-day commitment, but our average length of stay is about 4 months.
That's a long time.
And some people stay longer. We don't really have an end date, so it just kind of depends on the individual.
Lauren, for decades, your county, Rio Arriba, has been the epicenter for addiction and overdoses. And it's also a more rural area. So how do you focus your limited resources to be most effective?
Well, that's a really good question because in Rio Arriba County, in terms of treatment, the problem is not lack of resources, really. Mm-hmm. It's that resources aren't able to communicate effectively or work together effectively. And so Rio Arriba County, my department, we offer intensive case management, and we've pulled our providers together into a network. And this is to make treatment easier for individuals to access. And so what was happening to people in the past is they might get one component of treatment, and that's like getting one component of chemo. Mm-hmm. Like you can have the first round but not the second, or we'll just skip right to the third. Mm-hmm. It just didn't make any sense. And so what we do is we pull all the providers together, we share a case management software so that they're able to communicate. And because we're a network, they're now able to communicate without violating HIPAA. But we also, so we have different components of service, and we want to make sure somebody starts with detox, and then if they need residential, gets into residential, after residential, that they're in outpatient and different kinds of aftercare. Or other people they may be better off with outpatient and medically assisted treatment. But we want to make sure they get the right treatment. We drive them because everything is such a long distance away. We make sure they get the medical clearances and TB tests they need to get in, and it really, I think, helps ease them through the system.
How does the way services are funded complicate efforts to integrate mental health services and addiction treatment?
Well, it's sort of like dropping a bomb into the middle of it, honestly, because every different funding source has its own requirements, and they are often contradictory. So really, you're looking at some funding streams that come from the federal government, from SAMHSA, that are geared towards treatment. Other funding streams, probably the bulk of it, comes out of corrections. And so our goal in Rio Arriba is this is a chronic disease. And the police recognize this, the jail recognizes this. And
That's
so,
interesting.
Yeah.
So they've come to recognize that.
Right, and we have about, our jail is a tremendous burden on the county, but it's about 180 people that are frequent users, just like with the ERs. And so our goal is to get those frequent users who are there because of a chronic health condition out of the jail and into the treatment system where we can impact them.
Dr. Bott, how common is it for people who come to your facility who need help with addiction to also be dealing with mental health issues?
I think it's the rule, not the exception. It is extremely common. At our facility, one of the things we very commonly see, kind of similar to what you were saying, is histories of trauma and underlying post-traumatic stress disorder. I mean, I can say that about 2/3 of our patients have underlying post-traumatic stress disorder.
Wow.
And I think the data really bears that out, that when you look at people with substance use disorders, underlying psychiatric illnesses, particularly PTSD, is very common. And what the data also shows us, and what we know, is that if we want to address their substance use disorder effectively, if we want to treat it effectively, we can't treat it in isolation. We have to treat that post-traumatic stress disorder, that anxiety disorder, along with it concurrently. So I think
successful.
for it to be successful.
So what are the barriers to treating these things together? She touched on some of these.
Yes, I think there are several. From a provider standpoint, historically, there was this divide, right? If you had both, say, anxiety and substance use disorder, if you would go to a substance use disorder drug counselor, they would say, well, go take care of the anxiety and then come back and we'll address your alcohol. Because if you try to address the alcohol now, we'll make your anxiety worse. And if you tried to go to a psychiatrist to talk about the anxiety, they would say, well, go and deal with that alcoholism first because I can't really deal with you if you're drinking, right? And we've known for at least 15 years that that's not the right approach, that's not the optimal approach. But in reality, that change has been hard to come in practice. We still see, unfortunately, not just here, but around the country, these artificial divides, right?
Is it financial? Is it cultural? Or is it just systematic? Or?
It's all of the above. I know it sounds like a cop-out answer, but it's really all of the above, right? It's certainly funding related. It's also a culture and stigma, right? Substance use disorders are some of the most stigmatized illnesses in the world, and research really bears that out. And a lot of people are a little bit hesitant to have someone with alcohol addiction or opiate addiction come to their clinic. I don't agree with it, but unfortunately that's the case. And then there is also the issue of training and competency, right? Historically, substance use disorders were not emphasized in medical school education, in residency programs. So there is that, and even if people learn about it, there is a lack of confidence. Right, so I think it's a combination of all of those factors that sometimes perpetuate this, this essentially an artificial divide we have.
Dr. Taneja, at Casa de Salud, you work to provide behavioral health with addiction services like Suboxone, which is used to treat people addicted to opiates or heroin. Why is addressing things like trauma and poverty an important part of helping people deal with addiction, especially here in New Mexico?
Yeah, so in New Mexico, as we've talked about with Rio Arriba County, but also Bernalillo County and elsewhere, very high rates of opiate overdoses, very high rates of levels of addictions to heroin and opiate pain pills, more so compared to other parts of the country. And this has been going on for a very long time, and there's generational poverty and generational trauma and other factors contributing to this. we want to address the medical side, and as Dr. Bott said, there's so much stigma even among healthcare, and so that's an uphill battle that we're all working towards, and we're trying to meet people where they're at with medication treatment that is evidence-based and life-saving, but also trying to take this bigger picture of how can we look at root causes, or how can we look at this as something affecting our community and shift away from the more Western medicalized approach that sometimes has shame and guilt and blame kind of built in, and personal responsibility is such a huge piece of this. How do we see this as a community responsibility? And some of that is looking at the underlying traumas and actually addressing them in addition to the medication. So we have healing circles, we have talking circles, we have acupuncture, we have Reiki, massage, various different kind of mind and body, and somatic
Why is
therapies.
that effective? Can I ask?
Sure, yeah. Well, we see addictions as a mind, body, soul kind of picture. Let's address the addiction first with the medication and then wrap these other services around it. Trauma is healed in various ways, and part of that healing is through working through things in our own bodies. Part of that healing is working through things in our own communities. Part of our work, which is now funded by the Robert Wood Johnson Foundation Clinical Scholars work, is to try to engage people in a bigger picture piece of life also, so that they don't feel alone. A lot of our patients will get on Suboxone, be doing really well on medication, not having withdrawals, cravings, not going back to using heroin, but now they're locked up in their room and they won't go outside because everyone in their community or everyone that they interface with before, including family members sometimes, are still using. So their anxiety or the depression that they came in with is in some ways multiplied. So we're looking at building out civic engagement and offering optional opportunities, nothing mandatory, but optional opportunities for people to get involved in something bigger than themselves as part of this work around trauma. And so taking the best of medicine and taking the best of how we can approach trauma-informed care in a primary care setting, harm reduction with various services that we have, including a needle exchange for folks who are using heroin, as well as trauma-informed addiction services.
Do you have evidence it's working?
We are finally building a database of evidence for our specific work, but there is evidence around the country and in the world for programs that work that incorporate all of these aspects of healing.
Jennifer, at Serenity Mesa, you're offering kind of similar wraparound services.
Right, and we use Casa de Salud for our residents too. We take them there for the AcuDetox and the healing circles, and then for Suboxone.
How do you pay for sort of the wraparound services you're trying to offer so people can get housing and whatever things you need to be stable?
Well, and we get funding from the city of Albuquerque, we get funding from the state of New Mexico, we get some funding from CYFD, so we have kind of diverse funding. Some funding is more specific to certain things and other funding is more broad, but we do things like yoga, we do things like gym memberships and stuff that we fund mostly through fundraisers and things like that. Kind of extra.
Medicaid's not going to
No, unfortunately they don't cover things like that. Hopefully someday they'll realize that is, yoga, we've seen tremendous amount of response from our residents when they go to yoga. They don't like it at first, but it's as far as helping them deal with the trauma and almost opening up parts of their body that have shut down. It's amazing. It is amazing. And,
interesting.
And so I think, and we've worked with Casa de Salud quite a bit, and I think partnering with places that offer these services so that we don't have to reinvent the wheel and is a community approach that seems to be working.
Dr. Bott, the Affordable Care Act in some ways has made it easier to treat addiction and mental health issues. What would changes or even repeal of the ACA mean for New Mexico?
I think it would be honestly devastating. It seems like a strong word, but I've seen it. I started doing my work as a fellow in addictions back in 2009, and at that time, most of our patients paid for their medications out of pocket. And it was a significant expense. These are not patients, by and large, that we're treating that are rich. And it was, at times up to 30-40% of their monthly income was going just beyond the medications. And I think Affordable Care Act changed that, where for a lot of our patients now, these medications are affordable. It's drawn them more into treatment, right? And it's also allowed us to actually do more wraparound services. provide more of these wraparound services. And we've been able to build a lot of sort of psychotherapies for PTSD, also for folks with chronic pain, and they're able to actually access these services. And I do fear that, depending on what happens, we could go back to the days where where it's costing a significant amount of money, and it may in turn keep people from seeking the treatment that helps them. But beyond it, I think it is ultimately helping the entire community by reducing that burden of addictions.
It's also allowed us to begin integrating primary and behavioral health care. They used to be two totally different healthcare systems, which made no sense. And so pulling them together into one system along with wraparound services that you were both talking about is really valuable. And I cringe when I hear that there's talk of reinstating the mandatory minimums and the war on drugs. I think that is what is responsible for first of all, for creating the stigma, and secondly, for drawing so much money out of the healthcare system that people can't get treatment. So I really don't want to see people diverted to jail. It should be the very opposite. You're making it worse by increasing the PTSD and all the trauma when you put people in the jail system. Plus, when you felonize them, then they can't have a driver's license. They can't get a ride they can't carpool with one another because they can't be with other felons, so they can't get to their treatment.
Right.
They can't get a job. They can't get loans for school. It goes on and on. They can't get their medicine, whatever it is they need.
And end up giving up.
Yeah, and then it just makes the job of treatment providers that much harder because they can't be effective. And then you tell them, well, treatment doesn't work, we might as well just throw everybody in jail.
Dr. Taneja, there's stigma all over in the medical system, and it's shifting in the law enforcement, which is interesting. But we know things could go back that way. How do we address stigma and get away from it so we can do this more effectively?
It's a good question.
Could be the last question.
That's a tough question. I know in our fields of healthcare, it's been an uphill battle, but there's been some major shifts in the last few years around addiction, and so much of that has to do with educational centers shifting what kinds of topics are focused on. So much
As they train medical students and health workers.
and so much has to do with how widespread opiate addiction is in our community and in our country.
Yeah, the proliferation across America.
If you asked everyone in New Mexico if they knew someone who had overdosed or who was struggling with addictions, most people would raise their hands. So as this hits more and more families, this is something that is shifting. And I think in the healthcare field, we're realizing that we've entirely failed. We've just failed in terms of working with addiction in our community, and we're in an emergency situation. We have to be more responsive now than reactive. But in general, in the country, unfortunately, the increased rates of addictions are what are shifting a lot of people's minds about what's going on. And that's unfortunate for the folks involved. That's fortunate for greater awareness. It's also unfortunate in that this has been going on for many, many years, and the way we've treated, the ways in which racism and other things have come into effect, with Black and brown people generally being the folks who are those people, and now that's shifting and us having a better awareness and a more compassionate approach. This is part of what happens, and I think we have a duty to own that and be aware of that, and really aggressively work to shift our criminal justice system, to shift our healthcare systems, to shift attitudes in this country. So I think it takes everyone who's involved in this work.
I want to thank you all. It's a great way to end. I appreciate you coming and talking about this.
Thank you.
Thank
you.
you.
Thank you.